Chapters 15 through 17 cover the postpartum period for the neonate and the specific issues regarding neonatal care and assessment. Chapter 15 starts with the physiologic and behavioral responses of the neonate. The neonate is defined as birth through 28 days, and then the infant is 29 days to 1 year old. Our primary goals of neonatal nursing care include maintaining body heat, maintaining respiratory function, decreasing the risk of infection, teaching parents and supporting them in topics like nutrition, hydration, and care. The immediate changes in the neonate after birth include the head and chest are compressed in the birth canal, which expels about 30 milliliters of amniotic fluid from the lungs. It also squeezes the chest, which creates a vacuum that helps pull in a passive breath after delivery, which stimulates additional breathing and crying. A child who is born through cesarean section does not experience the exact same mechanism. The cord stops pulsing since there's no maternal and placental flow. There's a decrease in pressure, which causes the ductus venosus to collapse, causing fetal hypoxia, hypercarbia, and acidosis, which stimulates respirations. So essentially, when the cord stops pulsating, the lack of oxygen delivery combined with the CO2 production by the cells and the resulting acidosis stimulates the same triggers in the brain as we have with a hypercarbic state to breathe more rapidly and deeply, and this helps trigger an initial respiratory rate. Respirations can cause changes in the blood pH in a neonate, just like in the adult, and that will help shift the pH back into a normal range. And it also changes the pulmonary vessel pressures and flow, causing the foramen ovale and ductus arteriosus to close. The ductus venosus doesn't actually close until a little bit later, but that's okay. The APGAR score is taken at 1 in 5 minutes following birth. And it's important to note that of all of those things that we look at, the normal heart rate is the most reassuring finding of adequate oxygenation. A baby who is bradycardic is experiencing profound hypoxia or other problems like profound anemia, so it can't carry oxygen, or profound hypoglycemia, so it can't do the work, whatever the cause is, but eventually it leads to, hypoxia of the myocardium, which causes cardiovascular collapse and cardiac arrest. We have an acronym that we use in neonatal resuscitation, do what probably seems simple. And the first 3 steps are dry, warm, position. And then stimulation and suction only occur as needed. Stimulation really occurs during the drying process. So you want to dry the baby. You want to keep them warm, wrapped up, position them skin to skin, and on the mother's chest if possible. And then additional stimulation and suction only if the baby is non-vigorous. Thermoregulation is an issue that we talked about, but this is critical. The neonate needs to attempt to maintain normal temperature, and it can't shiver. So you and I, when we get cold, we shiver. And since the baby can't do that, it will increase movement. And as it's increasing movement, which would include, kind of jitteriness, irritability, arms and legs moving, head moving, it's using up glucose. So those glucose stores are going to get burned up pretty quickly, and hypoglycemia is going to occur. It's also going to try to vascular constrict to shunt blood into the core to keep the core warm. So you'll see pale, mottled, cool skin. And then brown fat metabolism, which is also referred to as non-shivering thermogenesis, will occur, but babies have more brown fat percentage-wise than adults, but not a lot of brown fat because they're little. And the more premature the baby is, the less brown fat they will have developed. So premature babies really don't have the ability to do brown fat metabolism. They also don't have huge sugar stores. So preemie babies especially are at super high risk for hypothermia and hypoglycemia. Again, I can't stress enough how much hypothermia and hypoglycemia go hand in hand. One pretty much leads to the other, and both should be addressed simultaneously. So because the neonate is going to try to attempt to maintain normal temperature, they're going to also be at higher risk for cold stress, which is hypothermia, than the full-term infant. So the premature infant's at higher risk because they have that less brown adipose tissue, they're unable to shiver, and they have a large body surface area. So to prevent cold stress, dry them, cover the head, skin to skin with mom, and warm blankets covering both of them. So that's dry, warm, and positioning. To treat cold stress, check again. Is the baby dry? Is the head covered? Are they skin to skin with mom? Are they in warm blankets? If that's not the case, then you want to swaddle them or place them in a preheated warmer and really monitor that temperature, check that glucose, and treat hypoglycemia that's less than 40. So normal glucose level for a newborn is 42 and not 60. So we're going to start being aggressive in treating it when it drops below 40, because as soon as they start feeding, it should come up. Routine care, in addition to APGAR scores, would be to monitor vital signs, temp, which is done axillary, pulse, which is apical, respiratory rate by watching the abdomen rise and fall. We don't really do blood pressures unless there's an issue, or O2 sat unless it's indicated, because it won't be accurate because of poor motor vasocontrol. Monitor I and O, so time on the breast or ounces in the bottle, the number of wet diapers and the number of stools, and you can weigh those diapers as needed, and maintain a neutral thermal environment. So that's really kind of our routine care. The neonate is at risk for infection, especially gonorrhea or chlamydia in the eyes during delivery. So erythromycin eye ointment is used to prevent blindness. You're going to use a 1/4-inch ribbon on the lower lids. And they're at risk for bleeding because the liver is immature and can't synthesize vitamin K yet. And somebody who has low vitamin K levels essentially has the same bleeding dysfunction as if they were on Coumadin. So we're going to give them vitamin K, which is phytonadione IM, and you want to use a 25 gauge 5/8 inch needle in the vastus lateralis. Undo the diaper on the side that you're injecting so that you have access to the entire thigh. And then do your good assessments. So your neonatal physical exam, your reflexes, and your maturational assessment. And those are found on pages 383 through 398 in your textbook. The normal neonatal assessment starts with looking at the general appearance of the child. So we're looking at the posture, and a flexed posture is normal. You're going to measure the head, the chest, the height, and the weight, and then obtain vital signs. The head is measured by placing the tape around the head just above the ears and the eyebrows and recording the measurement in centimeters. The chest is measured by placing the tape around the chest just over the nipple line. And again, the measurement is usually in centimeters. It's usually a smaller circumference on the chest than the head. The length is measured by putting the baby kind of flat on its back, so supine, and extending the hip and the knee and measuring from the top of the head to the bottom of the heel when the foot is flexed. So extend the body one leg and measure from the top of the head to the bottom of the heel. And that is also usually measured in centimeters, but told to the parents in inches because most people don't remember centimeters. Weight, remember to zero the scale with whatever it is that you're going to weigh the baby on. So if it's just like a paper sheet, then zero the scale with a sheet. But usually we weigh babies in when they're very, very newborn. We oftentimes will weigh them swaddled in a blanket. So you're going to zero the scale with a blanket, swaddle the baby, remove the diaper. Only weigh the baby, so make sure you're zeroing out whatever else is on there with the baby. Temperature should be done axillary. Sometimes we'll do a rectal temp if the baby seems critical, or if their APGARs aren't coming up, or if they haven't stooled within the first 48 hours. Respirations are checked. Usually 30 to 60 breaths per minute is normal, and they should be slightly irregular. And remember that babies are belly breathers, so you want to watch the abdomen rise and fall. And the rate increases when they're crying or decreases when they're sleeping. So it's best if you can do this when they are awake, but just kind of quiet and looking around. The pulse is usually 120 to 160 beats per minute, but it's regular. There's a slight variation with breathing, but not a significant one. The rate can increase to about 180 if the infant is actively crying, and can slow to as low as 100 when the infant is sleeping. Murmurs may be heard in this early stage that usually disappear, but if mom was on any antidepressants or anything like that that increased the risk of heart defects, then the baby would probably be sent for cardiac echo, which is an ultrasound. Again, blood pressure is not usually taken. The skin is assessed again at 1 minute and 5 minutes during the APGAR, but then throughout the stay. The skin should be pink with some cyanosis of the hands and feet, just because they're not well perfused, so the body's going to shrink those blood vessels. Lanugo is usually present on the back, the shoulders, and the forehead. The jaundice, anything jaundice within the first 24 hours would be considered pathological. That would be an abnormal finding. And pallor, if the baby looks very pale, we would be concerned about things like anemia, hypothermia, hypoglycemia, shock, sepsis. Look at the shape of the head, just like you would for an adult. Is it equal from side to side, or is there molding? Look at the neck. It should be short. There's a lot of skin folds. You really have to lift the skin, and you can look at the picture on 386. You see how they're like really gripping and lifting the skin and the chin so that you can get a clear picture of the neck. This is also something you want to teach to the parents so that they can actually do good skin care. This is one of the areas where we see a lot of yeast infections because people don't actually clean the food out underneath the chin and the skin folds. Look at the eyes and determine the position of the eyes in relationship to the ears. Look at the ears themselves and make sure that there's no drainage. Look at the shape of the ears and make sure that they appear regular. And a hearing test should always be done before discharge. Look at the shape of the nose. Inspect the opening of the nares. They should be patent. Any infant who's having a really hard time breathing or feeding sometimes will suction all the way from the nose into the mouth to make sure that the nare itself is patent. Oftentimes there's a small amount of mucus, but remember that they're obligatory nose breathers, so we don't want them to have anything else in their nose. Look at the mouth, the lips, the gums, the tongue, the palate, the mucous membranes. You're looking for any teeth, looking for thrush, cleft lip, cleft palate. You're looking for a tight frenulum, which is also referred to as tongue-tied, and then Epstein pearls. Check the chest and the lungs. Look at the shape, the symmetry, the excursion, so equal chest movement. Breast engorgement can be present in both male and female neonates because of maternal hormones, and it usually goes away within a few weeks. Just reassure the family that that's normal. Clear or milky fluid might be discharging from the nipples of male or female neonates. Again, normal. It's just hormones that were transmitted through the blood from the placenta. Scattered crackles are detected usually during the first few hours after birth from the amniotic fluid, and again, that's absorbed through the lymphatics and it goes away, and that's a normal finding. Persistent crackles, wheezes, stridor, grunting, paradoxical movement, decreased breath sounds, or prolonged periods of apnea are all signs of respiratory distress. So please take a moment on 388 to review normal and abnormal lung sound findings in the newborn. Cardiac, again, you're going to listen to the PMI or the apical pulse. It's a little bit higher on the newborn, so it'll be third or fourth intercostal space instead of fifth. And S1 and S2 should be present. You should hear lub and dub. Again, you may hear a little bit of a murmur, and that will go away on its own. For the abdomen, you want to look at the size and the shape. Make sure that the abdominal wall is intact. You don't see any hernias. Auscultate bowel sounds and inspect the abdominal cord. Passage of meconium stool should be within 48 hours post-birth. So urine within 24 hours, stool within 48 hours. The cord should be opaque or whitish, and there's 2 arteries and 1 vein. Remember that the cord itself is filled with a thick substance called Wharton's jelly. It will become dry and darker in color within 24 hours and detach usually within 2 weeks. So one question that a lot of parents have is, how long do I have to wait for this to come off? And you just tell them it's normal for it to detach within 2 weeks. Inspect the anus. The anus should be patent and stool should pass. Now, in this one it says 24 and above it says 48 hours. So you gotta love that when the book disagrees with itself. Genitourinary female. Look at the labia majora and minora. They may be slightly engorged or edematous initially after birth, and you might notice some blood-tinged vaginal discharge related to hormones. There's also sometimes some whitish vaginal discharge. All of that is normal. The swelling goes down and the discharge stops. The neonate usually urinates within 24 hours. It's super important that good pericare gets done, and so you want to teach the parents how to do appropriate pericare on the female. For the male neonate, you want to check the testes to make sure that they have both descended. The scrotum might be large and there might be some fluid inside, which would be a hydrocele. That's when you have an enlarged scrotum due to excess fluid. That also usually resolves on its own within the first 18 months to 2 years. For musculoskeletal, you're going to look at the clavicles and you're going to look at the hips. The legs should be symmetrical in length and equal in strength. Check to make sure they have 10 fingers and 10 toes. And then you want to turn the baby over onto their belly and support them and make sure that they don't have any tufts of hair or any difference in the number of gluteal folds from right to left, which would indicate hip dysplasia, right? And then the tuft of hair or the sacral dimple might be indicative of neurological problems as well. So look at the baby. Neurologically, they should have a flexed position, so they should have good muscle tone, rapid recoil of the extremities to the flexed position if you pull them down, and positive reflexes. For your documentation, review the common newborn characteristics, like acrocyanosis is a term we use a lot where the hands and feet are blue. Mongolian spots are flat, bluish discolored areas on the lower back or buttocks that we talked about in the physical assessment portion of this course. You'll see those with people who have African American, Asian, Hispanic, or Native American descent. Erythema toxicum, milia are in there. Lanugo is the hair that kind of covers the baby. The vernix is that kind of white cheesy coating that covers the baby when they're born. There's a nice picture of jaundice on 392 in case you've never seen it. There's a picture of molding on 393 where you can see the head and how the head adapts to the birth canal. And then two issues that arise sometimes, oftentimes with either use of surgical instrumentation or from a prolonged labor are caput succedaneum, and it has the initial CS, caput succedaneum, and remember that that means it crosses the suture line, so CS crosses sutures. And this is localized soft tissue edema of the scalp. It feels very spongy. It's like a serosa. It's just fluid, and it resolves on its own. So it's just, it's not a hematoma because it's not blood, but it's just an injury. Cephalohematoma is blood, and it does not cross the suture line. This usually occurs, again, from either prolonged labor or like forceps or vacuum. It can cause jaundice, which is interesting because when you get a hematoma, the red blood cells then are destroyed. And so when you have a larger volume of erythrocytes being hemolyzed, you end up with more bilirubin in the bloodstream that the immature liver can't filter out. And so that actually could be an underlying cause of jaundice. Epstein pearls is on there, and natal teeth as well. So the newborn reflexes start on page 394 in your book. Morrow and startle are the same thing, but basically when you jar or startle the baby, the arms and legs will abduct and it kind of extend and kind of flex up against the trunk, and the little hands make a little C. So that it's basically like a reactive, like, oh my gosh, like what'd you just do to me? The tonic neck is the fencing one. So if you put the neonate in a supine position and turn the head to the side so the chin goes over the shoulder, you'll notice that the hand will bend behind the turned head and the other arm will extend. Rooting occurs to help the baby feed. So if you brush or stroke the side of the cheek near the corner of the mouth, they'll turn their head and open the mouth. And this is one of the reflexes that we really want to teach mom to help her improve feeding if she's breastfeeding especially, but also with bottle feeding because it's just as important with bottle feeding that the nipple get put all the way in. Sucking is when you stimulate the roof of the mouth, so you stimulate the hard palate, the baby will start sucking. When you do this, you want to put the non-nail side, like of your gloved pinky finger, up against the top. Palmar and plantar grasps occur when you touch beneath the fingers or beneath the toes, and either the fingers or the toes will turn down and kind of grasp your finger or whatever you're touching them with. And then Babinski's are normal in babies, should disappear by a year, and then are an abnormal or pathological finding in adults. And that's when you stroke the lateral surface of the sole in an upward motion, and you get hyperextension and fanning of the toes. And then the last one is the stepping or dancing reflex. And that's where you hold the neonate upright, the feet touch a flat surface, and they'll step up and down in place. And that's just related to an immature neurologic system. Once you've done your reflex assessment, your neonatal assessment, we also do the Dubowitz neurological exam and the Ballard maturational score. And those help us just determine neuromuscular and physical maturity and basically how old the child is developmentally in relation to how old they are chronologically. So there's examples of these on 397 and 398 just to give you an idea of how they're done. And when you're thinking about like when should I do my assessment, look at page 399 and read through the periods of reactivity. So during the first 6 to 8 hours, the neonate will go back and forth between periods of activity and inactivity, and we refer to those as the periods of reactivity. So the initial period of reactivity is within the first 15 to 30 minutes after birth, where the neonate is very alert and active. They're very vigorous in their response to any stimuli. The respirations oftentimes are irregular and rapid, and they might have some grunting, flaring, and retractions, as well as brief periods of apnea as they're trying to figure out like how to breathe and balance out their O2 and CO2 and their pH. Their heart rate can be rapid, as high as 180, because they're stressed and trying to adapt to extrauterine life. And sometimes they get brief periods of cyanosis from just kind of confusion and vasomotor control. Then after about 30 minutes and up to about 2 hours, they start to enter this first period of inactivity where they will sleep. And they'll be very tired at this point in time. Their vital signs start to normalize a little bit. And then at about 2 hours, they'll enter a second period of reactivity. And this will they'll go between an active alert and a quiet alert state, kind of back and forth. You have to think about when you're doing your assessment how their vital signs are being impacted by which period they're in. So that initial period, that initial 15 to 30 minutes, is a great time for parents and the neonate to spend some time together. It's the ideal time to start breastfeeding, and then the child will sleep for a little while, which is a good time for mom to get some rest or to get cleaned up. And then during the second period of reactivity, the neonate is going to be interested again in feeding, sucking, and another time for breastfeeding. A lot of people have written into their birth plans recently that they want, a minimum of 1 to 2 hours of uninterrupted skin-to-skin contact. And really what we're looking at is that first full phase, so that first initial period of reactivity and then inactivity where the mother and the baby can bond and they can kind of relax together. The Brazelton Neonatal Behavioral Assessment Scale is also on page 399, and it talks about 28 behavior items and 18 reflex items that was initially used for research, but now is sometimes used in the clinical setting, and this isn't one that we use at our hospital. So, some danger signs. When you're thinking about how do I really differentiate between my kid who's doing okay and my kid who is in distress? So the first thing you're going to look at is mental status. So a child who is lethargic or seizing or jittery, or obviously just irritable, uncomfortable, in distress, that would be a problem. Look for respiratory signs like tachypnea, retractions, grunting, nasal flaring, those cyanosis. Hypotonia would be a sign of hypoxia, which is why it's on there. But, look for those signs as being a respiratory problem. For cardiovascular, then, you have also the tachycardia or the bradycardia, or you have, the kid who has the hypotonia. And then for skin, you're looking for pallor, cyanosis, jaundice, things like that you would report. Other would be temperature, instability, hypoglycemia, failure to pass urine or meconium, and abdominal distension. So we talked about the importance of avoiding cold stress, and really you can decrease the risk of cold stress by putting the baby skin to skin, keeping them dry, covering the head, and keeping mom and baby together and warm. And then you treat cold stress if it occurs with the more aggressive putting the kid under the warmer, swaddling them and checking their temperature routinely. So cold stress, when you're looking at the definition, this is on 400, temp less than 97.7, pale, cool skin, lethargy, hypotonia, a weak suck, so the inability to feed. And this becomes a problem now because kids who get cold need more glucose and they have a problem eating, so they can't actually take in glucose. Tachypnea, grunting, hypoglycemia, jitteriness. And so we might have to place an NG tube, or we might have to start an IV to give them some glucose. Phenylketonuria is addressed in this chapter as well. It's an inborn error of metabolism, and neonates with PKU cannot metabolize phenylalanine. And so it starts to the kind of side effects build up within the body, and they will start to have seizures, permanent brain damage, and even death. We have rules in Vermont that you can't leave the hospital without being tested for PKU. But a lot of people want to sign themselves out at like 24 hours and go home. And if they do that, then they have to come back. Because ideally the test is done at 2 to 5 days after birth, because feeding has to be established. There is phenylalanine in breast milk, and so whether they're breastfed or bottle fed, they will be getting phenylalanine, and within 2 to 5 days, they'll start to have an accumulation of the metabolites within the body. For a heel stick, you want to warm the heel for at least 10 minutes with a moist cloth. Use the lateral aspects of the heel to avoid the nerves. Collect your sample. If you do have a baby who tests positive for PKU, the treatment is low phenolac, which is the formula, and then lifelong dietary restrictions and monitorability levels to prevent brain damage. Circumcision. So some of you have gotten to see circumcisions, but circumcision is the surgical removal of the foreskin. And it can be done sometimes as a religious preference and sometimes just as a personal preference. There are some medical benefits to circumcision and there are some drawbacks. So it is really a personal choice. Currently, we just provide a lot of literature and allow the family to decide. It is still covered by insurance. We want to pre-medicate with Tylenol about an hour ahead of time, and then right during the procedure we're going to give them sucrose, which is like a liquid on a pacifier or on a gloved finger, to allow them to do non-nutritive sucking, which is for self-soothing, and the sugar itself helps treat the pain. We use a circumcision board as a restraint for safety so that they're not moving around and that they don't actually accidentally get cut anywhere else. And then teach mom and dad how to appropriately dose and administer Tylenol. We want to do that for at least the first 24 hours. There's Vaseline gauze or like Xeroform gauze around the wound to prevent the diaper from sticking, which will allow that to just fall off on its own. It's open at the top so they can still urinate through it. Sometimes it falls off right away. If they do have to apply additional Vaseline or bacitracin or whatever, you want them to do it kind of like a creamy, like a soft serve ice cream cone around the tip of the penis. And reassess frequently for bleeding, because remember, again, babies are at risk for hemorrhage, so it's important that we're looking at that for bleeding and swelling, and teach for signs and symptoms of infection. All right, chapter 16 covers discharge planning and teaching, and really our goal is to prepare the parents to be successful in their transition from the hospital to home. Teaching should be individualized and really just based on the needs of the newborn and the parents. So think about, what do they need to know about nutrition, hydration, and newborn care based on the answers that they've given you on their questionnaire or your discussions with them or what you've observed in their interactions with the child. So things that we want to talk about would be abusive head trauma, which is shaken baby syndrome. It's never okay to shake a baby. Babies cry a lot, normally up to 30 to 40 minutes at a time. It's okay to put them down in a safe place and walk away, call someone to talk to, but it's never, 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 never okay to shake a baby. It's not unusual to feel overwhelmed when you have a little one at home, and it's okay even for them to call us, but there's also hotlines within the state, pediatricians, neighbors, friends, parents, family members, you know, whoever. Bathing, babies don't need to be bathed really routinely. More importantly, they just need to be wiped off. So if there's food or dirt on them, they should be wiped off with a clean washcloth, and then the skin should be pat dry. The peri area should be cleaned with diaper changes. If they are going to bathe, they should clean from the cleanest area, the eyes and face, to the dirtiest, which is the genitalia and the rectum, and never leave a child alone in, with, or near any water, because a baby is head heavy and can drown in as little as 2 inches of water in the bottom of a bucket. Circumcision and cord care, monitor for bleeding and signs and symptoms of infection, redness, pus, warmth, discharge, foul smell. Diapering, wipe front to back and avoid pressure on the cord before it falls off, so show them how to roll the diaper. Again, show them specifically how to do good pericare and make sure that all stool is removed. If they are going to use powders, lotions, whatever, we recommend that they don't use them until the baby is at least 6 weeks of age, because of the inability of the baby not to absorb things through their skin. So whatever they put on it will be absorbed through the skin. Feeding, sucking, soothing, and swaddling are kind of hand in hand. So we want to teach parents how to hold and comfort their children, and how to recognize the cues that they're wet, hungry, tired, in pain, and how to really address those. And it's important to differentiate between nutritive and non-nutritive sucking, and teaching them about clothing and how hot they need or how much they don't need to bundle their children is important as well. Before they're discharged from the hospital, we want to schedule their follow-up appointments and make sure that they understand when to return, and what to report if anything strange occurs before then. We do a lot of teaching about feeding as well, so breastfeeding versus bottle feeding. So the first and probably most important thing is that it's not us, it's them, and whatever they want to do, and there's no one right way. These babies have never had other parents, so in the baby's mind, whatever the parent is doing is the right thing and the perfect thing, and so we really just need to help them be the best parents that they can possibly be for whatever decisions they make. They can decide to do both, they can decide to do one or the other, or they could try one and have it not work and have to switch to the other. That's totally fine. We just need to be really positive and focus on what they can do and help them be successful in transitioning to parenthood. So we know that breastfeeding definitely has some advantages: the optimal nutrition, ease, availability. You don't have to store it. Thank goodness you don't have to put mothers in the fridge. But it's always there when you need it, as long as mom is there when you need her. It does lead to decreased childhood infections, hospitalizations, obesity, asthma, ear infections, sinus infections, things like that. The colostrum is present for the first up to 3 days, which is really high in protein and immunoglobulins. Then the transitional milk occurs in the first 3 to 10 days, which has an increased number of carbs, fats, and calories so that the baby can grow. And then the mature milk comes in somewhere around a week to 10 days. The fore milk tends to be more water to make sure that the baby is well hydrated, and then the hind milk tends to be more fat. So what we really want is for the baby to drain one breast before you move to the other breast. And so sometimes what moms can do is pump on one side while the baby feeds on the other, or feed the baby and then pump both sides to make sure that they're really draining the breast completely to get both the fore milk and the hind milk for the baby. And so then if they're saving milk up to feed the baby, a bottle, or for when they go back to work or the baby goes to daycare, they'll have a combination of both foremilk and hind milk. If the baby feeds, foremilk on both sides and no hind milk at all, they're not going to really get like adequate or ideal number of calories. And then the pumped milk is going to be all hind milk. Breastfeeding does have some contraindications. So moms who are actively using drugs, alcohol, or meds that pass across the membrane into the breast milk should not obviously be dosing their infants. So moms who are getting chemo or radiation can't breastfeed. And if there are open lesions or sores on the breasts, then that would not be okay for the baby. If the baby has PKU or galactosemia, so they need a special diet, they wouldn't be able to breastfeed. And in terms of HIV positive moms, if they have access to safe water or prepackaged formula and they can afford it, then they should go ahead and use that. But if their choices are, unclean, well water or breastfeeding, then they should do breastfeeding. Bottle feeding also has some advantages. It allows other people to partake in the feeding and bonding between other parents or providers. It's digested more slowly, so the baby has to feed less often, and so sometimes bottle-fed babies will sleep better through the night. The disadvantages obviously are the cost, where breast milk is free, bottle feeding is not, and it takes some time to prepare and clean up. The biggest thing though is storage and making sure that, because it's expensive, people try to stretch it out. So sometimes they'll put in too much water and they'll thin it out, and that's really dangerous for babies. Or sometimes they, will let a bottle be out too long and try to refeed it to an infant to save money. And none of that really should happen. We have to stress that that's incredibly dangerous and it can make their kids very sick. Infants have growth spurts. So one of the important things to teach is that, they will feed more at 3 to 5 days, 1 week, 6 weeks, 3 months, 6 months. And during those times, they're going to cluster feed to try to get more food so that they can grow. And they'll start solids at about 4 to 6 months age, one at a time. Some danger signs that parents should be aware of and call the physician or seek medical care immediately if the child or their newborn infant has a fever of 100.4 or higher, if they have stopped feeding or only feeding poorly, if there's a decreased number of stool or wet diapers in any 24-hour period, if the child becomes lethargic, and lethargic means that they don't wake up to their full alert state at all, if they start to notice green watery stools, which should be a sign that they either have an infection or they're having a problem with their food, vomiting, a rash of any kind, bulging or sunken fontanelles. And when you're teaching this, teach the parent to use a flat hand to assess the fontanelles and never poke at it with a finger. And then infection, like a cord care or cord or circumcision infection. We also want to make sure that we do SIDS prevention education with the back to sleep. Breastfeeding and the use of a pacifier both decrease the risk of SIDS. Do not swaddle for sleep. Sleep sacks are great. We don't want to put any extra items in the crib, so no pillows, no stuffed animals, no big blankets, no loveys or whatever. Everything should be out of there except just the baby, which is why we've moved to kind of using those sleep sacks, which are like a blanket you can zip your kid up in, so that those can't get kind of caught up around their face. There should never be any smoke exposure for newborns, and this includes passive secondhand smoke. So parents who smoke outside still are off gassing when they come in, and that increases the risk of SIDS. And don't overheat. So that's the other big thing is kids who get overheated tend to have a higher risk of SIDS. Parents who use drugs and alcohol tend to be at the highest category for SIDS deaths. Chapter 17 then looks specifically at the high-risk neonatal nursing care. The preterm infant is considered very premature if born before 32 weeks, premature between 32 and 34 weeks, and late premature between 34 weeks and 36 weeks and 6 days. Remember, at 37 weeks, they're considered to be term. In addition, the gestational age by Ballard score is at or below 37 weeks. On page 441, Table 17-2 reviews the risk factors for preterm labor and birth. One of our largest concerns with premature infants is apnea and bradycardia. With apnea comes hypoxia, which causes acidosis, which causes bradycardia, which causes cardiovascular collapse and death. We use apnea monitors on these babies, and sometimes they're sent home with them. And then kangaroo care, promotion of early breastfeeding, temperature stabilization, and bonding. It's really important with premature babies, remember, to provide a neutral therapeutic environment. And our goals include fluid and electrolyte balance and nutrition and promotion of breastfeeding. Apnea is defined as 10 to 15 seconds of no breathing, and bradycardia is less than 100 for the neonate. I'm going to talk about next, but retinopathy of prematurity occurs most often in preemies under 28 weeks, and this is when we have prolonged hyperoxia from a mechanical vent, usually, and we have a decrease in vision, or we have vision loss. We want to do ABCs, blend the oxygen so it's a lower concentration, wean them off of the vent as soon as we can, and avoid bright lights in the nursery. So now to go back. So necrotizing enterocolitis is inflammation and necrosis of the bowel. We see this most likely in preterms. 90% of our cases actually are preterms. It has a 30% mortality rate. Onset is usually within 3 to 10 days after delivery. And this is basically overproduction of bacteria and gas within the abdomen. So signs and symptoms are shock, they're septic. They have abdominal distension from the bowel loops becoming incredibly distended and full of gas, bloody stools from the infection itself, vomiting, and lethargy. The treatment is to manage the ABCs, to make the child NPO, to put it in a gastric tube for decompression, and then do IV fluids, surgery to remove that part of the gut, antibiotics, pain medications, and antihypertensives. And those are sick little kids. Post-mature neonates, ones that are born at 42 weeks and 0 days or greater, are also at risk for some problems. Typically, they have macrosomia, so they're at 4,000 to 4,500 grams or greater, which would be 8.8 pounds or higher. And they're at risk for things like meconium aspiration from stooling in utero, fetal hypoxia, neurological complications, hypoglycemia from oftentimes mom having diabetes, hypothermia, polycythemia, and birth trauma. Meconium aspiration syndrome occurs more frequently in post-mature neonates than any other group, and the signs and symptoms, or the hallmark signs and symptoms of meconium aspiration are a non-vigorous newborn that has meconium in the airway. The meconium had stained the amniotic fluid, not just like, when the baby was being squeezed out and you see it in the legs, but you see it all over the child, like you see in this picture. The mech itself got below the glottis, so it's below the cords. It's actually down into the lungs because the baby stooled in utero and it mixed in with the amniotic fluid and the baby was practicing breathing. It actually got it down into the lungs. And this causes respiratory depression at the time of birth, which can be life-threatening because it doesn't allow gas exchange to occur at the level of the alveoli. So the treatment for this is direct tracheal suctioning. if there's bradycardia, apnea, or hypotonia, but it needs to be done obviously by somebody who's trained in intubation. So the nurse's role would be to assist with delivery, suctioning, and resuscitation, and to assist the provider with direct tracheal suctioning. You could set up for the intubation, but obviously you wouldn't be the one doing it. You would dry, warm, position, suction, stimulate after delivery, but the first thing would be to clear the airway. And remember that bradycardia is a clear sign of hypoxia, and so if that were occurring, then that would show you that obviously this child was in distress. And that is a really great picture of meconium, by the way. Jaundice occurs when we have hyperbilirubinemia. It's the yellow discoloration of an accumulation of bili within the blood, and this usually occurs because of a rapid breakdown in red blood cells. And remember that the baby has an immature liver, and the liver is usually the one that filters out the bilirubin and turns it into bile, and it collects in the gallbladder and turns our stool brown. So the risk factors for hyperbilirubinemia are hypoxia, breastfeeding, and ABO-RH incompatibility, so an Rh negative mom with a Rh positive baby, oxytocin or delayed cord clamping, cephalohematoma, because then you have like a large hematoma and all those red cells are destroyed, or poor feeding, because pooping actually helps alleviate some of the bilirubin, because the bile then is excreted into the GI tract to help break down the food, and then the body makes more. So eating is actually a good way to get rid of jaundice. It's considered pathologic. It occurs within the first 24 hours, and those are the kids that end up usually under the Billy lights because we're worried about brain damage. It's physiologic if it occurs after 24 hours. The treatment for jaundice is airway, breathing, circulation, safety, normothermic environment, feed, hydrate, monitor INOs, phototherapy. So they spend 18 to 20 hours a day under the lights, only with their diaper on and their eyes covered, as you see there. You want to hold them for feedings so that they get some bonding, and change positions frequently. So of the 4 to 6 hours that they're not under the lights, they should be cuddled, snuggled, and loved on as much as possible. So just to review some terms, small for gestational age or intrauterine growth restriction is anything that decreases blood flow or nutrients. Things like smoking, vascular disease, cardiac disease, and chronic hypertension would decrease the amount of nutrients that reach the placenta and therefore the fetus, so you have small for gestational age. Large for gestational age, again, is macrosomia, greater than 4 to 4.5 grams, which would be 8.5 or greater pounds. Common with post-mature neonates, mothers with diabetes, or multips. And when you have macrosomia, there's an increase in postpartum complications. AGA is appropriate gestational age, or appropriate for gestational age babies. So those are some terms in this chapter. And then neonatal withdrawal, or neonatal abstinence syndrome. And this is covered on 469 in your book. So crying, irritability, restless, frantic sucking with an inability to be consoled, congestion, sneezing, yawning, hyperreflexia, tremors, and poor feeding are all signs of an infant who is actively withdrawing. And there's a critical component table on 469. We treat them, right, with soothing and sometimes with actually replacing the chemical that they're missing. So trying really hard to get these kids to withdraw as safely and quickly as possible. So those are the highlights of our 3 chapters relating to neonatal care. And let me know if you have questions.